Austin Faith Dialogue, a public affairs program at the crossroads of religion and life. A series of programs highlighting the social and cultural interaction between the worshiping and larger communities in and around the capital city. Austin Faith Dialogue is brought to you by the Austin Area Conference of Churches in cooperation with KTBC. Join us now in today's Austin Faith Dialogue.
Hello, I'm Richard Thompson, pastor of Central Presbyterian Church, and your host for today's Austin Faith Dialogue, brought to you through the Austin Area Conference of Churches. Our topic for today is medical ethics, the Austin case. The ethical issues of medicine in the 1980s, of course, are not limited to the capital city of Texas. Whether it's surrogate mothers, as made widely known through the Baby M case, or the prolongation of physical life never be to return to human consciousness, as in the case of Karen Quinlan, the moral dilemma is a national one and a worldwide one. Yet the people who are working through the issue, both in theory and in practice, day to day, encompass our local health professionals and theologians. In hospitals, research institutions, seminaries, and churches, a multitude of questions are raised by medical technology. Now, among the persons serving on hospital advisory committees in the Austin area dealing with medical ethics are two of the physicians in the Austin community, Dr. Russell Hoverman and Dr. Peggy Russell. And Dr. Jack Stotts is president of Austin Presbyterian Theological Seminary. And we welcome all three of you to this discussion about medical ethics as we confront it in this particular place. And I think that the appropriate thing for us to do is to pick up with the committees that you serve on. I understand, Peggy, you're at St. David's as a member of the Advisory Committee on Medical Ethics.
That's correct.
And Jack, you are on the Seton Medical Ethics Council. Mm-hmm. And Russ, I understand you're on both of these.
Right.
So I believe we'll begin with the work at St. David's. And what are some of the issues that have been brought to the committee since you've been serving on it, Peggy?
There are basically two types of issues. There are some policy and procedure issues that the hospital, various departments or the administration of the hospital may want our opinion on. We serve as an advisory committee, and perhaps in implementing a new policy or procedure, they would like to know what the ethics committee would recommend or what other perspective the ethics committee thinks the hospital should look at in considering the issue.
Okay, could you give us some examples of those issues that are brought to you?
Recently, we had to discuss the Texas state laws regarding organ donors and how the hospital would approach the persons requesting organ donations, how they would approach families within the hospital, and what the policy would be and what information would be disseminated.
Okay, so organ donations that would make a difference in a life and death situation in each of these cases.
Well, we are trying to identify organ donors. So that means identifying a person who would be dying and would be a potential donor.
All right.
And how their family would be approached and what issues would be involved in approaching that family.
Okay,
So
well, go ahead. I want you to
the
finish
other
that.
part, other than policy and procedural, is in individual cases. And physicians, nurses, family members, or patients have the Ethics Committee available to them to ponder individual cases.
So it can come from either direction in terms of the staff or the people who are being treated. Jack, as Peggy has mentioned these at St. David's, is this along the lines of the issues that have been brought to you?
Very similar. I think it would be very much like Peggy has mentioned. And I guess the only other thing I would say, which may be a little bit of the same, when new issues arise, new questions that arise, a fairly recent one, though we don't think of it as recent, was the whole AIDS question, for example. Mm-hmm. Well, how does one approach that question? And again, advice is being sought. It's not a question of saying do this or do that, but what advice would you bring to bear upon the question? Treatment, testing, things of that sort.
Okay. And in regard to the ethics of AIDS dilemma, how the testing would be one thing that
would be certainly one question, right?
But that's not limited to testing.
No, it would not be limited to testing, but there'd be a whole range of questions that might be brought up around that area. But the question of general policy, I think, is the one we're talking about here.
All right.
Access to medical services would be one of those.
Okay, we'll come back to, I think, both of these illustrations, but I think first, Russ, I understand you've done an article for the Texas Medical Journal.
Right.
And what was the subject of that?
Well, what we tried to do was identify areas that it would be reasonable to withdraw nutritional support. One of the issues has been using the Texas Natural Death Act as a way to allow a patient to have their wishes down ahead of time so that they wouldn't have to be put on a respirator or be resuscitated if they had a terminal illness. Well, the Texas Natural Death Act only covers something defined as a terminal illness. It doesn't cover long-standing depleting illnesses like Alzheimer's, dementia, or people who are in a chronic vegetative state.
More of a critical condition.
Well, it's exactly what you talked about with Karen Quinlan. It's somebody who will never return to consciousness, will never return to any sort of definition of health that we look at, but who will cost maybe the family or the state or somebody maybe $100,000 a year just to keep them supported. And what we've done is try to identify, number one, those people who we would think it reasonable to withdraw nutritional support, and provide a mechanism to go about doing it, very similar to what the Texas Natural Death Act does, to have physician approval, have family approval, and an ethics committee only if there needs to be a forum for discussion.
So what the state of Texas has done is to provide a framework within which it's possible to decide on these in terms of a consensus, and it's not automatically precluded to withdraw food and nourishment.
Food and nourishment has always been something, well, any kind of prolongation support has always been something that has been between the patient and the physician and the family. But there are fears for the patient and their families that they will get caught in this network and never be able to get out of it. And there are also fears on the part of the physician to some degree that they would still be liable if they withdrew any of these supports. So the Texas Natural Death Act provides some protection for both. It provides some autonomy for the patient and their family, and a mechanism for physicians to feel comfortable doing what they've been doing for a long time.
Well, I think that, Jack, as we hear Russ describing this particular withdrawal of life support system in that way, you come to the faith traditions that will vary in terms of what they feel is moral, ethical, and not. How would you, as a theologian, identify the variety of points of view in terms of religious traditions in regard to any one of these issues that's been named so far?
Well, one thing that strikes me from what Russ said is that when you talk about ethics or a moral decision, you're really talking about a decision that is surrounded by layers of concerns. That is to say, the legal question is one question. The question of what can be done medically is another kind of a question. There are all kinds of questions. One of them, and one of them only, is the particular tradition out of which the person comes, whether it's the patient or whether it's the physician, or it might be the institution, the hospital. What kind of faith tradition does it represent? If it represents a particular tradition, it will tend to make a decision about certain issues one way or other, otherwise it may leave the question open. For example, a hospital like Seton, which is a Roman Catholic hospital, would have a particular tradition which it represents and which it is going to uphold. That would be a particular strength or weakness, depending upon your perspective, for that hospital. That would not be the same true of St. David's Hospital, it seems to me. They would have a different kind of a tradition which shapes their perspective.
Could you give us an illustration of how the Roman Catholic perspective would bear upon an example or two of ethical issues?
Well, I think just as an example, the whole question of abortion, the Roman Catholic Church has a particular tradition of teaching on that subject, and it seems to me that's if you're a Roman Catholic patient, if you're a Roman Catholic physician, if you're a Roman Catholic institution, you want to represent that in the best way possible, and would understand that. Another tradition would be represented by the Episcopal tradition, and that would be of a different sort. Different factors would be brought into bear in making that decision.
Now, Peggy, as a physician serving at St. David's, which had an Episcopal background as it was originated community, do you find that you're not limited to Episcopalians on your medical committee, I presume?
No, not at all. I've never felt that there was any formal, well, implied or otherwise, religious influence in
You have
making...
clergy on your committee?
Yes.
All right.
At least 2 clergy members.
And you have physicians? Do you have, who else is represented from?
There are several physicians. There are people from departments in the hospital, including nursing, social services, administration. Then there are 2 or 3 people from the community that represent various humanistic foundations, and we have a few attorneys.
All right. So you do have a fairly broad spectrum, 15 or so that are working on the committee. So that we might have a sense of how you work, could you give us a story of an issue that's been brought to you and how it was resolved, and with reference to what kinds of faith traditions or philosophical resources that may have come into play?
There are various issues that have been considered. 2 or 3 of the ones that we've considered in the last 6 to 7 months have been related to a person who was near death and what care should be given to prolong their life, and in this instance usually prolong dying, or to allow the quickest death possible. The physician would come and represent the medical side of the case.
Okay.
There would be people who had interacted with the family, but family members weren't present. And the case would be presented to us, and the dilemmas being faced would be presented to us. In other words, this is how much medical care we can give in the next few weeks or few months, or this is the option: if we stop giving medical care, life will end fairly soon. And why those decisions would even be considered, whether it was because of the family's feelings, the patient's previously expressed desires not to live when things were hopeless. And then we would just lay out the whole case to discuss what were the medical possibilities of meaningful recovery, what was the likely type of existence.
You have a particular instance in mind that you're thinking of as you
I'm
describe
thinking
this.
of 2 or 3 cases that we've
right.
discussed that are along similar
And giving us a sense
grounds
of how the process works
in the committee.
in the committee.
All of these are very individual.
All right.
That's the only case that we, in terms of a particular, rather than policies, it's just individual cases. So a physician lays out for us the medical aspects of this case and asks us to help him or her consider the issues at hand and how they should make the next decision.
All right. Well, you mentioned the prolongation of life, which we associate probably most often with people who are elderly, and yet it is not limited to that. You have mentioned, in the case of Karen Quinlan, for instance, where something happens that the person's conscious life is no longer operative, Russ, and if you come back to the beginning of the life cycle, where children are coming into the world, Do you have instances that have been brought to you on either one of these committees that have dealt with matters of newly born?
We've had a couple. The issue is still the same, though, although maybe the emotional content is much greater. The attachment to a newborn infant, however ill, may be higher than it is to somebody who's lived their life and has already made a wish about how they wanted to end their life. But the issues are still the same. The issue is the potential, the quality of life, the wishes of the family. Some of this decision-making has been taken out of the hands of physicians by the government with what are called the baby doe laws, where there's, in essence, no physician is allowed to discriminate against handicapped newborns. And the question is, how handicapped does a newborn have to be before you allow it to die? So there is this other aspect, as Jack has said, this other layer over these kinds of decisions, but still the decisions are basically the same. And we've had some recent ones, and a lot of the issue is discussing with the family what the options are. Sometimes the families don't know all the medical facts, or don't want to, or haven't had a chance to discuss everything, to know what the consequences of their choices are. So it's a forum as well as an advisory committee, and sometimes all we do is facilitate discussion.
Okay, and you don't necessarily come up then with a recommendation to take to the administration of the hospital. You may simply lay out options and...
For these individual cases we do, but for policy issues, for instance, the business of withdrawing nutritional support turned out to be a recommendation to the administration, and it became hospital policy. And the same is true for the request of potential transplant donors. That also is a request from the administration for an opinion from the ethics committee. We don't set policy, but it's possible that we can have something to do with making policy for the hospital.
I'd like to move as much as we can in the time that we have left from the broad issues and the rather abstract issues of policies, recommendations and so on, to what this, you touched on it, and it brought to mind, you know, the kind of agony that people go through when it's not a story in the newspaper, it's their own situation. It's their own child, or their own parent, or someone that's close to them. And I think, Jack, as a person representing the religious resources that are available in the working through of these dilemmas, do you see that there is anything distinctive that the faith perspectives has to bring that would make a difference in terms of the kind of personal impact and emotional dimension to what takes us beyond the legal and the medical?
Well, I think there's several things, but maybe to start with, I'd say that one of the resources that a religious perspective might give one is the recognition that none of these cases are very simple, that they're very complex, and they're often a conflict of various values. I think both Russ and Peggy have mentioned that. There are various kinds of factors that have to be brought into play. And the religion, I think, can at least help people to understand that often in cases like this, there is no simplistic or simple answer. And that's a very important kind of decision to make. You have to take into account a lot of factors. And the second is that you can surround that person, whoever is making that decision, whether it's a physician or whether it's the patient or the patient's family, with a sense of the high importance of the decision that's being made without having a burden of guilt about the decision. That this is an area where you have to make some difficult decisions, which are not always clear. The consequences are not always clear.
So dealing with the guilt is
dealing with the guilt,
religious
and
concern.
also with the sense of life as broader than physiological or biological.
All right.
That life consists of our being human beings in relation to each other, as well as being physiological or biologically defined. So you have you can bring, I think religion can bring a sense of the richness of the definition of life, which may give some help to people as they make decisions, which are always very difficult decisions because they're decisions about ourselves and our families and human beings.
All right, I think that you're bringing out the fact that it's not simple,
Right.
and that there are some religious traditions that say that it is simple. You know, it's life and death, and life is very clearly defined in one way and death in another. And yet it seems to me, I believe it's something, Peggy, that you suggested, that there is a shifting as technology becomes more sophisticated and these issues are presented in a way that they may not have been a generation or two ago, that our whole understanding of what life and death is being challenged.
And the limits of life have become so complex. Whether one of us would die today because some very sophisticated technology might be withheld. For instance, were we not put on a respirator, some kind of mechanical support to breathe, which could keep us alive in a certain condition for a few weeks or a few days or months, versus without that technology, how our life would have suddenly ended. And each area of medicine has its own contribution in terms of drugs and antibiotics, simple things like feeding that used to, if you couldn't eat and drink, then that was it. You wouldn't be fed. And now we have so many sophisticated ways to feed people, whether it's intravenously, whether it's through a tube through their nose, whether it's through a tube through their stomach. A lot of choices just about how to feed someone who would otherwise die of starvation. And trying to present those options to a family, rarely to the patient, because generally at that point they cannot meaningfully participate in the decision process. But to present that to a family is very confounding.
All right, let's just focus on that for a moment. The issue, for instance, of placing a tube to stomach feed someone who is unconscious and is not able to eat on their own. That decision by the family, by the physicians, and so on. Russ, I'd like for you to speak as a doctor now, not simply as a member of this ethics committee, but as someone who's had to deal with people that have had to make these decisions. Can you share with us what it is that makes it possible for you to advise them, to deal with their feelings? What resources do you bring into play as a person, as distinct from your expertise as a doctor and those kinds of dilemmas?
Well, I think the main contribution I can make is honesty. And the way I can make that is by best knowing how to describe the possible outcomes. I think as an example, if someone has a head injury in an auto accident, any number of possibilities may happen. They may recover, they may not, they may be in a coma forever. And it's important for me to make a best judgment early on so that we can help the family make those kinds of decisions. In Alzheimer's cases, it's easier. We know at a certain point there is no recovery, and that putting a tube in to feed will not help the patient. So all I can do is offer a best guess and give those numbers as I see them to the family to help them decide.
So the honesty, the forthrightness, there's a certain service that you render in terms of matter-of-factness about it, I would suspect, and yet a sensitivity to the agony that they're going through.
So it's hard business. I mean, you go and tell somebody that there's nothing you can do, and that's not what we've been trained for. It's been we're trained to rescue, and so that being honest, our obligation is still to the patient. So being honest is sometimes difficult, but I think we owe it to the people that we deal with.
Jack, you're president of a training institution for future ministers. How are you training these clergy-to-be in the skills that it will take to counsel with families in regard to these medical ethics issues?
Well, I think there are two areas. One is the courses we offer in the area, for example, biomedical ethics. And those would be offered as available to all the students, and they would be offered along with schools like the nursing school, so that one could get with the kind of basic theoretical foundations. The other, we do a lot through what we call the clinical pastoral education programs, which are related to the hospitals. And there the student is assigned to work with a chaplain at the hospital under the supervision of that chaplain, and is given assistance in trying to understand and learn how to interpret what's going on, how to relate empathetically to the patient, to the family, and to learn from the supervisor about how you work also with physicians, so that the physician does not bear that burden of life-death questions by herself or himself, if that physician chooses to call on others to be of help, surrounding the patient with other kinds of help.
And this may not be through a committee, but on the ward? Or
right on the ward. I think it often is right on the ward, more often than certainly in a committee.
Right. Peggy, we've talked a little bit about how ministers to-be are being trained in this regard. Let's think just at the conclusion here about the future. How would you see medical personnel, doctors, nurses, being more adequately trained to cope with the moral, ethical dilemmas and the personal availability as well?
The situation right now is rapidly evolving. There is a great deal written and talked about locally, nationally, and internationally about all these issues. And it's just a burgeoning issue. I think that as the forum for discussion continues to grow and more opinions enter in, that serves as a source of education and a source of enlightenment. On several levels, just locally, the American Cancer Society asked me to give a workshop recently for the social workers on medical ethics. I've dealt with it through hospice program. We deal with it at the hospital and ethics committee. Medical schools frequently will have lectures on that.
So you've really broadened the base in terms of going beyond medical schools and the curriculum of formal institutions to community-based institutions.
Exactly, because it's just like the composition of the ethics committee is multidisciplinary. Whenever you come up with these decisions, they have to be multidisciplinary. And so involving as many people who are in the healthcare field and not as possible is important.
Well, we very much appreciate your involvement in our discussion today. You've each made a splendid contribution, and as we bring our reflections to a close, I would extend thanks not only to the panelists who have helped us define the issues involved in medical ethics and how to relate these to various faith traditions, but to thank you for watching with us as we've dealt with this particular dilemma through the Austin Area Conference of Churches. I'm Richard Thompson, inviting you to be with us next week. Thank you for watching. Good.
For more information about today's topic, call the Austin Area Conference of Churches at 472-7627.